Welcome! The following presentation from Answers in CME is part of an educational activity titled From Screening to Specialized Care, Navigating Key Questions in Alpha-1 Antitrypsin Deficiency-Associated Liver Disease. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. Supported by an educational grant from Takeda Pharmaceuticals USA Incorporated. This is a unique CME program. We've conducted a survey with hepatologists, gastroenterologists, pulmonologists, primary care physicians, including pediatricians, nurse practitioners, and physician associates to gather their feedback and questions about alpha-1 antitrypsin deficiency-associated liver disease. Our faculty will now address the most commonly asked questions.
My name is Virginia Clark. I'm a professor of medicine at the University of Florida. Welcome to From Screening to Specialized Care, Navigating Key Questions in Alpha-1 Associated Liver Disease. In this first session, I'll discuss the importance of early recognition of Alpha-1 Associated Liver Disease. In the survey, clinicians really wanted to know why it's important to detect Alpha-1 and liver disease. Let's start even simpler. What is Alpha-1? It's a rare inherited disorder caused by a genetic mutation in the SERPIN1 gene, which reduces the serum circulating level of alpha-1. Alpha-1 is widely recognized for its association with early onset pulmonary emphysema, but it's important to understand that hepatic manifestations such as liver fibrosis, cirrhosis, and hepatocellular carcinoma are also a significant clinical presentation of the disease that contribute to morbidity and mortality. Unfortunately, liver disease is not as well recognized. What is the pathophysiology of alpha-1? It starts in the liver. The genetic change causes the protein to fold abnormally and then it ends up accumulating inside the liver cell. And that causes a proteotoxic stress on the liver, which ultimately can lead to liver fibrosis and cirrhosis in about 10% of individuals who are PIZZ. In the lung, there's decreased circulating levels of alpha-1, and so the lung is not protected from proteolytic lung damage from neutrophil elastase. That leads to lung emphysema prematurely. Why is it important to detect alpha-1 early? It's because every year of diagnostic delay leads to loss of lung function and lack of an opportunity to stop smoking, which can accelerate this process. In liver patients, many of them are diagnosed not early, but once liver disease is already present, and ultimately about 15% of individuals who are diagnosed may require a liver transplant. Because alpha-1 is a rare disease, it can be difficult to accrue enough patients across these studies to draw a lot of conclusions about the natural history of liver disease, especially when we have a large population that might be undiagnosed, which is why detection can lead to better outcomes and better study and research. Even more importantly, early detection of an inherited genetic disease means you can discuss testing with family and potentially identify additional patients. Unfortunately, most individuals with alpha-1 currently are undetected. We know that about 6% of the population in multiple studies worldwide are diagnosed, and that leaves the majority of individuals undiagnosed. And it may be because they don't have symptoms or signs, but it may be because they have symptoms, but people are not thinking about testing for alpha-1. The average length of time before patients have a symptom and are diagnosed with alpha-1 is between 7 and 8 years. And the test is so easy, we've got to find a way to improve that. So which patients with alpha-1 are at the highest risk for liver disease? Individuals who are PIZZ have the highest risk for liver disease. This is because of the accumulation of the abnormal protein within the liver, but if you're an SZ or MZ, you still have some risk of liver disease over your lifetime. It's important to know once you identify these patients. So the Z is the problem. It is the most common pathogenic variant associated with alpha-1. But the development of liver disease and the severity of liver disease is also impacted by other genetic and clinical factors. As people age, men have higher risk if you have diabetes or if you drink alcohol or have other coexisting liver insults. These are all modifiers of risk liver disease and progression, and so we have to think about these in patients that are affected. In the next session, I'll discuss screening and the diagnosis of alpha-1 associated liver disease. In this session, I'll discuss screening and diagnosis of alpha-1 associated liver disease. Going back to our survey, clinicians wanted to know how patients at risk of alpha-1 liver disease should be identified. So who do we test? A recent consensus statement suggested that anyone who had recurrent or elevated liver enzymes, any degree of hepatic fibrosis with a score of F2 or greater, including cirrhosis, anyone with a family history of alpha-1, any history of neonatal cholestasis, or any history of alpha-1 associated extrahepatic conditions such as paniculitis, all should be tested for alpha-1 liver disease. Individuals who have been identified who have emphysema or COPD, all should also be tested for alpha-1 because it's a genetic cause of COPD. How is alpha-1 liver disease defined? There's a new nomenclature around what it means to have liver disease in alpha-1. First, you have to have the highest risk genotype, which is be an adult with ZZ, and then you have to have an elevated liver enzymes in some way, or it doesn't matter, to have some degree of liver fibrosis, because you don't have to have elevated liver enzymes to have alpha-1 related liver disease. How can these patients be identified in clinical practice? The first step for screening is to test the serum concentration level of the alpha-1 protein in circulation. And if your level is very low, then you've identified someone who is at risk for the severest form of alpha-1 and therefore liver disease. Once you've identified that person, then we have to confirm the diagnosis of alpha-1. The next step for that is to perform genotype testing and then to risk stratify. Once we identify someone who is a ZZ, they need to be referred to genetic counseling and pulmonologist if they have any signs of lung disease. Or if you've identified someone who is an SZ or an MZ, consider other cofactors and what their risk factors for liver disease are, and counsel on what their lung and liver risk are. So the genotype does impact who should be monitored for the development of alpha-1 liver disease, because remember, if you're a ZZ, you're at the highest risk for developing liver disease long term. In the next session, I'll discuss how to assess liver function in patients with alpha-1. In this session, I'll discuss how to assess liver function in patients with alpha-1. One of the questions we received in response to our survey was how to assess liver disease in alpha-1 antitrypsin deficiency. A recently published consensus guideline addressed just this fact. The most important takeaway is that we need to stage fibrosis at the time of diagnosis to decide if they are low risk, intermediate risk, or high risk. This can be done with blood-based imaging or imaging non-invasive test. The preferred test in the consensus guideline was to use transient elastography. However, this is not available to everyone, and so blood-based tests may be appropriate for staging as well. If you have a test that suggests advanced fibrosis or fibrosis, a secondary confirmatory test with transient elastography is recommended. Once you have identified fibrosis and where the people fall, whether their risk category is low, intermediate, or high, based on this transient elastography, then monitoring intervals reflect this. If people are low risk for progression, monitoring is every 2 to 3 years, and those at highest risk have monitoring interval suggested more frequently. The other question is, when should a liver biopsy be performed? This is often a clinical decision that you have to make. Alpha-1 is not a diagnosis that requires a biopsy to confirm, because this can be done with genetic testing. The role for a liver biopsy is really a clinical question. If you have someone who has fatty liver, or if someone who has alcohol use, or you have someone, if you're looking for an alternate cause for liver disease in addition to the alpha-1, that's when a liver biopsy might be helpful, or when your non-invasive measures don't agree and you need more definitive staging for fibrosis. In the next session, I'll discuss the evolving treatment landscape of alpha-1 liver disease and look at some of the emerging therapies. In this session, I'll discuss the evolving treatment landscape of alpha-1 liver disease by looking at some emerging therapies. How are alpha-1 associated lung and liver disease treated now? Well, Unfortunately, there are no approved pharmacological treatments for alpha-1 associated liver disease. Liver transplantation is the only option for individuals who have cirrhosis. Augmentation therapy is used for individuals with lung manifestations, but it doesn't help individuals with liver disease. Insights into the pathophysiology of alpha-1 have led to several potential treatments targeting the misfolded protein. So what are these therapies that are being investigated for alpha-1? There are therapies that specifically target the liver and some that might target the liver and lung, and we're going to start with the one that's the furthest along, which is fazirsiran. Fazirsiran is a small interfering RNA molecule that works to inhibit the messenger RNA degradation specifically targeted to Z-alpha-1 antitrypsin. This results in reduced production of protein within the liver and reduced accumulation overall, and I can share those data with you now. Fazirsiran was granted breakthrough therapy designation in July 2021 and orphan drug designation in February 2018. In an open-label phase 2 study of adults with PiZZ genotype and liver fibrosis, fazirsiran reduced the alpha-1 concentrations in the serum and in the liver. What I'm showing you here is the primary outcome, the primary endpoint, with the reduced serum circulating levels at every dose level of fazirsiran. In addition, what this nice waterfall plot shows you at every dose level, there was a reduced content within the liver of all the alpha-1 after a duration of therapy with fazirsiran. There were no safety signals found in the trial, and for this reason, a large phase 3 trial, Redwood, is now evaluating if treatment with fazirsiran reduces liver scarring in individuals with alpha-1 antitrypsin deficiency. What about BEAM 302? BEAM 302 is also being investigated for individuals with alpha-1. The mechanism of action for BEAM, it's a DNA editor using a modified CRISPR protein and a base editing enzyme to make a change in the DNA so that normal alpha-1 is produced. And what we've seen so far in very early data is that in a dose escalating manner, you can see, or what has been demonstrated, is that serum circulating concentrations of alpha-1 after the genetic change was introduced was demonstrated after a single infusion. This is very exciting, but also very early data, so we have to wait to see for further results. This third mechanism of action is an RNA editor, and the mechanism is very similar, except that using the deaminase is targeting the RNA level instead of the DNA level. This makes it a little bit more reversible in terms of the mechanism overall, and the early data suggests that we haven't seen a lot of data, but proof of principle is there that the normal protein levels can be achieved. In the next and final session, I'll discuss monitoring and multidisciplinary care. In this fifth and final session, I'll discuss monitoring and multidisciplinary care. Based on our survey, clinicians wanted to know about how to monitor patients ongoing and how to involve multiple practitioners. So how often should liver function be monitored? I would say individualize it to the patient that's in front of you. It's all based on risk assessment for what their fibrosis level is and what their other known risk factors are, as we discussed earlier. Those at highest risk require more frequent monitoring, and those at lower risk, it's less frequent. When should patients be referred for liver transplantation? This is a new study has recently shown that individuals who are ZZ for alpha-1, it's actually associated with higher risk of complications and rates of faster decompensation than other etiologies of cirrhosis. So it's important to keep that on your radar. And if patients with liver disease decompensate faster, you may want to consider liver transplantation early in their course once cirrhosis has been identified. When should patients be referred to a pulmonologist? Right away. Every individual who's newly diagnosed as a ZZ alpha-1 should get a baseline lung function test and then annually thereafter. What you can do is you can leverage the expertise if you have it at your center, or look for one that may be local that your patient can travel to. There's a lot of information from patient organizations such as the Alpha 1 Foundation in the United States and other patient organizations across the globe that are easily accessible online to connect patients to the right resources. So in conclusion, I would say Alpha 1 is a rare condition, but it's also underdiagnosed, so look for it. We have trials in progress right now that are trying to look for therapies for liver disease, and I'm optimistic that in the future we will have a therapy for liver patients with Alpha 1. Thank you so much for your attention today, and I hope you've learned something.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.